I do want to provide you with a little bit of background of my history, because I think it does give you some perspective of where my head is. I'm agnostic in terms of my belief in the healthcare system around the globe. My position is a global position. So I represent Fin partners around the world. My colleagues from Fin Partners Israel, based in Jerusalem, are here, and I thank them very much for arranging this. My work has transcended different sectors of healthcare. And so when I look at this presentation and my advice to you, keep in mind, I'm not recommending any one path. It's based on my experience. And I'm actually a little older than I look, or I like to believe I'm older than I look. I'm closer to 120 than you would imagine. So I've spent time, first and foremost, as a health provider. Then I was a lobbyist for the pharmaceutical industry quite a few years. I worked in the federal government, putting together what's now called the Part D system. This is the system in which American seniors access drugs at special prices subsidized by the US government. From there, I founded my own communications organization. It was relatively successful, and like many of you, I was acquired, or many of you desire, I was acquired. I spent a number of years as president in a global organization that's now owned by a very large French company called Publicis. From there, I went to take on a global position in communications in a firm and was promoted to become vice chairman of strategy in the parent company called WPP Group, which owns firms like Ogilvy and J. Walter Thompson and others. From there, I went to private equity. I told you I'm very old. From there, I went to private equity, a large private equity group that has about $4.5 billion in active management. I was responsible for healthcare investment. And from there, I stepped back. You know, many of us were busy on a career path that is really not determined by us, right? We're answering the call to action of the need to earn money, to keep ourselves employed. That's an honorable thing, by the way, being able to pay your food bills. And also opportunities that cross our path. I think a lot of us do that in life, right? We tend to do that which was presented to us. So at that stage in my life, I actually asked myself a very important question, which we don't ask ourselves enough, which is not what should I do that's being presented to me, but what is it that I want to do? And actually for all of you, because you're entrepreneurs for the most part, and an entrepreneur has to be courageous. An entrepreneur has to be bold. An entrepreneur has to have some form of belief. Belief in what they're doing matters in the world. So I would encourage you to, at some point, to stop for a moment and ask yourselves, are you doing what you want, and do you believe in it? And in the context of that, I decided actually to dial my career back, not step down, but actually go to a place that I had the most amount of fun, and that's the practice role. And I've dedicated myself to be responsible for practice leadership. I love it, and I enjoy it, and in this country and in other countries, I have the opportunity to work with some of the best people in the world who are passionate about changing the face of healthcare. Despite everything you're doing with technology, despite the desire and the need to raise capital, and I will bring that in because I know that's what is driving many of you, I believe deeply that what we do will make a difference in this world. And that ultimately, if we're only about creating commerce for the sake of commerce, then actually we're part of the problem of the global healthcare system. We're part of elevating the cost of the system. If we can find within ourselves a moment of reflection and a belief that we will improve the human condition in this country and around the world, then I'm confident that our innovations will be meaningful and valuable to society. If you cannot answer that question about what you're doing, I can assure you it will probably not be successful. So in the context of the presentation today, I'm going to touch on many things. What I'm asked about most frequently, and I shared with Levy earlier, is an editorial where I'm quoted immediately in the beginning of the editorial, is I'm asked right now about, have you heard the name Donald Trump? I guess some of you have, okay. I'm asked most frequently, how will the president-elect impact the world's largest healthcare system? And I'm going to actually start off presentation and give you a reflection, because I believe there has never, ever been as great a time of possibility for Israeli companies in the health technology area as there is right now going into this administration. I'm, by the way, politically agnostic also. I'm, as they say, apoliti. I have no political point of view. I'm an analyst at heart. I analyze data. That's what clients pay me to do. By the way, who are the clients that I work with? My colleagues in Israel work with many of you, as does טיטאן Brandwise. But for the most part, my work is spent working with the CEOs of some of the largest health companies in the world. That's where I spend my time. So the reflections of this presentation are actually filtered through my conversations with those guys. So I'm bringing you an outside-in view of the world. I am a cheerleader for you. But more importantly, I'm a realist. And I don't want to dampen anybody's enthusiasm. Heaven forbid, I actually want to do the opposite. I want you to leave this meeting that Michal and Levy have put together supercharged for the future, with a belief that you can really change the future of healthcare. Part of the reason, by the way, I believe that you can do that in this nation is the concentration of talent that exists in a very small area. There is so much going on in the startup nation in Israel in terms of health technology that, you know, Levy has, either by design or by accident, I don't know, he knows, but he has created really one of the most vibrant trade association communities in the world. And I am on a plane constantly. I actually came here from California. So what Levy is doing and you are doing together, that concentration of talent will enable you to succeed. Now, why is this a time of great opportunity? Before I begin these slides and go into this, keep in mind the election of Donald Trump is not a game changer for healthcare. The Republicans have controlled Congress for 8 years. Everything that's been done in the past 8 years has been done with the Republican control of the Senate and the House, the two deciding bodies of government that drive things through. And that's one of the reasons why you hear, I think many of you have heard that the Affordable Care Act will be repealed. Has anybody heard that? Raise your hand. Everybody, okay. But they call it in the United States now, repeal and delay. Repeal and delay. Well, what does that mean, repeal and delay? The president-elect wants to live true to his promise. The first thing I want to do is repeal that act. Okay, and then what is he going to put in its place? Nothing. He's going to keep it. He's going to repeal it and delay any change to the system. So there's not going to be any real, fundamental, immediate change to the system. There will be, ideally, but we're dealing with government, there's going to be supposedly thoughtful shifts in how it works economically. I would urge you in your business plans, I'm going to put my private equity hat back on for a second, everything you do, for the most part, when you're presenting it outside, do a very good economic analysis of the value of your innovation in terms of the system. Even the previous presenters who were wonderful, it was great, Livy, that you were able to secure them as they ran for the airport. While they weren't this specific, my takeaway was economics, economics, economics. Who's going to pay? Someone's asking that question all the time. Who's going to pay for this? In the United States, the big thing that's going to come out of the change of the election is that's going to be front and center. It's no longer going to be on the back burner of conversation. They're not going to be so diplomatic about it any longer. It's going to be brutal, who's going to pay? So I started to tell you who my client base is. So I work with people like the heads of companies like Merck, Bristol Myers Squibb, Johnson & Johnson. Maybe you've heard of some of those companies. I also work with the large insurance plans. I'm on the Strategic Communications Council of one of the largest health insurance plans in the United States, Blue Cross Blue Shield. We work with the federal government. We work with about 50 different patient associations, of which I serve as an advisor to some of them, and I'm the chair, one of the chairs of the American Heart Association in the United States, almost $1 billion organization in its own right. So my presentation is filtered through those interactions. And the questions I encourage you to ask me, be as bold as you want. Ask. I'm here to help you succeed in the global marketplace. That's my sole purpose of being here today. Now, I too am leaving today. I guess when Levy holds a meeting, everybody wants to leave afterward. Actually, I have colleagues here in the room. One is standing there, Goel, Jasper, and if you need to grab me, you can grab either Levy or Goel, and they'll get in touch with me. I'm happy to help. I'm happy to help. That's the purpose of being here, and that's in the spirit of what I think Michal and Levy are doing. They're trying to create a community of people who are willing to turn to each other and support each other, and I applaud all of you for that. That's one of the reasons why when Levy asked me to come in for one of his forum, I'm happy to do so, because I think he approaches everything with this very good heart to help. It's a real, real, real privilege to have someone like that in the community. So thank you. You can applaud this guy again. Thank you very, very much. So here's the thing. When I'm in this country and in the United States has passed this phase. I hear this conversation constantly, big data. Big data, big data. We're involved in big data. You know, I was introduced to I don't know how many companies in the past, 4 days. Maybe, I don't know, maybe 20 or so companies I met with. Of the 20 or so companies, I'd say more than 50% of them said, we're involved in big data. And that's become a real buzzword. So avoid it. When possible, avoid the term big data, because I think that's like, we don't know what to call ourselves, so we'll say we're involved in big data. And from the other side of the table, it's really about the me. And that was said very wonderfully by the previous predecessors. People don't want to be known as the part of the molecule of the big. They do want to be known as unique. And actually, the marketplace has gone to a different term. You probably have heard this buzz term also. And if I'm invited back again, I'll give you a new term to avoid: precision medicine. And precision medicine results from our analyzing tons of snippets of data. What we're really looking to do in the context of therapies or immunotherapies, or in terms of demographics that allow us to look at hotspots of health. Hotspots of health are actually, we suddenly see disease pockets of a lot of people with an illness in a geographic area. Now you've got to ask yourself, in the United States, in an area with a zip code, why is it that a ton of people have diabetes? You know, that's a really interesting question. Is it their economy? Is it that they don't have good food to eat? Is it that they eat Kit Kat bars all day? What is the reason for this? And part of it is genetic pockets. People come to areas, they're not mobile, they have diabetes, they have kids who have diabetes, who have kids who have diabetes, and suddenly we have Camden, New Jersey. It's a major city outside of Philadelphia, for those of you who know Philadelphia. And suddenly we find out in Camden, New Jersey, not only do we have the highest crime rate in the United States, we have the highest population of people with diabetes in the United States. If we stayed in that universe of like big data, we would never get down to the granularity of what is going on here. And that's really what, for those of you who are involved in data collection, or like we're collecting data, try to bring the term down to something that's meaningful and valuable. Big data is theoretical. Don't be theoretical with the marketplace. That's one. Two, most of our therapies today that rely on big, like cancer immunotherapies, they're going to be stress going forward. And by the way, Merck's big product in cancer immunotherapy that's taking the world by storm is, I don't know if you know, an Israeli innovation. And some of you are nodding. It's Israeli innovation. That's you guys. That's why I'm here. You guys will change the world. So the biggest problem when I'm on the payer side of the equation, I represent both. I'm the middleman, right? I'm in the shook, going back and forth between the two. And when I'm with them, the payers say, how do we get out from having to use products like this? These specialty medications are killing us economically. They cost a fortune, and it's not that they cost a fortune, that they work on maybe 30 to 40% of the population that uses it. So the payer pays for 100% of the patients who get the drug, but 25% of the patients show any clinical response. Don't answer this question. It's rhetorical, which means I'm just asking it for the hell of it. Do you think a payer in 2 years is going to continue to pay $200,000 a year for something that works 25% of the time? I don't think so. But they've got to, and I'm going to talk about that. They've got to because of the power of me. When Mrs. Smith is standing in front of you crying to the doctor that her husband has lung cancer and it's his only shot, and Dr. Jones is on the phone with the plan screaming at them that they're going to kill his patient because this patient needs a shot at this drug, what's a payer to do? They're kind of in a really messy situation. So when you're thinking through what you're going to do, if you're on the therapeutic end or the diagnostic end, I'm going to try to cover everything in the time allotted to me. And if I don't, I guess I'll be invited back again? Yes? No? Okay. This is the shot. Take it for what it is. He said no. Okay. So I'm going to try and cover every sector that's sitting in this room in some way, shape, or form. And then I'm going to leave enough time for questions so that you can ask specifically what you need at that moment. So here is the reality of the American healthcare system. The American healthcare system is not monolithic. It's fragmented. And you come from a very holistic healthcare system. This is where Israelis, believe it or not, are soft and tender. They're no longer those sabarim. You're not sort of like prickly on the outside and soft and sweet in the middle, right? Your system works actually pretty well. How many of you who are born and bred in Israel have changed health insurance more than 3 times? Raise your hand. Nobody. How many of you, I'm just curious, have the same health insurance program your parents have? All of you. Wow. What's going on here? Are you clones of your parents? No. You have a closed-loop healthcare system that, although you have to stand in line and that sucks, it works. And more than that, you go to a doctor, if you're a Maccabi patient, who do you see? You see a Maccabi doctor, right? And the Maccabi doctor writes a prescription for a drug. Where do you get the drug filled? At a Maccabi pharmacy. Wow. And if you have to go to a diagnostic test, like a mammogram or something, where do you go? Probably a Maccabi radiology center or, I don't know, something like that. It's a closed-loop system with very good electronic health records. Pretty cool. America has none of that. None of that. It is literally like living in the middle of the Negev in a tent in America. It is big, it is expensive, it's screwed up. And so you come to the States with your idea and people smile. Now I'm going to put my private equity hat back on. So I was in private equity. How many of you met with private equity firms before? Oh, a good amount, a good amount. Here's what's going to happen, because I've been on this side of the table. You're going to meet with them, and they're going to do this. And they're going to then nod a lot. And then the hour meeting is going to be a 2-hour meeting. And they're going to ask a lot of interesting questions. And you're going to leave the room and say, yeah, right? That was a great meeting. I'm sure they're going to write a check tomorrow for $1 million. No, they're just collecting information. That's it. It's all about them. It's nothing to do with you. They're collecting information from lots and lots of companies. They get smarter and smarter about the space. I'm going to talk about this fragmented system because what if you understood the system? What if? And that's the hard part here. That's the very hard part here. So within the what if is you. And yeah, you probably have some marketing idea and sales idea, and you have a legal counsel on the regulatory system, and you have a medical advisor, and you have people looking at running around like Levy who's helping you out and making introductions. All good. That's the B. That's the U. And now we're dealing with the B2B2C ultimately, right? And that's all this. And none of this is connected, but it all speaks to each other simultaneously. They all influence each other, generally to the status quo, which is nothing gets done. And that's why America and the Affordable Care System is classic American healthcare. Nobody agrees, and therefore it's stymied. So there are 5 sectors to the American healthcare system. Your business plans have to give some thought to these 5 sectors. I'm going to review them. 1, you have to clarify what you're doing and why it has value. That's you. That's 1P. Product innovation, whether it's digital, diagnostic, pharmaceutical, it's a gadget, it's a device. Product innovation. Why are you valuable? Why are you needed? I understand it's nifty. I see a lot of nifty things. Why are you needed? Next. Providers, physicians, hospital systems. They operate on throughput. They have doctors. By the way, do you know, like the Maccabi doctor is a salary-based doctor. He or she gets paid a salary from Maccabi. You know where American doctors get paid from? Any idea? Insurance. So what does that mean? Who really pays them? Don't say the consumer. That's not correct. I mean, consumers pay insurance companies, or employers do, but it's not correct. Actually, doctors pay doctors. Well, doctors pay, let me explain this. So, an American doctor doesn't earn a salary. They do not earn a salary. So you can say, well, how do they drive Mercedes-Benzes if they don't earn a salary? I mean, how can that be? Are they living on the Ashrai, on the overdraft? No, they're not. What happens is it's a fee-for-service system, which means you go into the doctor's office and you say, I have an earache. A woman who goes into the doctor's office has an earache. So the doctor, first of all, has a nurse do a pulse ox test. They put a little clip on your finger. Ever see that? Want to see the oxygen in your blood? $600 for that. $600, so they're going to charge the insurance company. They're going to get back $25. Okay, next, they're going to check your blood pressure. They're going to look in your throat. They're going to look in your eyes. That's an office visit. That's about $250. They'll get some money for that. Then they're going to say, I don't see anything. Is it bothering you? You're going to say yes. He's going to say, or she's going to say, let's do a CAT scan. It could be a brain tumor. They're going to send you out for that, right? Yeah. Are they a radiologist? Do they read those things? No. They get a piece of paper back, and they have to read the piece of paper. They charge, literally, for reading the piece of paper. And so all you really needed is some wax removed from your ears. But $15,000 later, that's determined. And that's how the American healthcare system is making money or not making money and becomes very inefficient. Here, in Maccabi, usually what happens is you go in, you have an earache. He says, can you stand it? You say, yes. Yes, he says, get out of here. Next, right? That's the system. So, and if you're not dead in 2 weeks, then guess what? It was probably just some wax that fell out of your ear and you're okay. It's a very, very defined system. America, if a doctor wants to earn $600,000 a year, they'll figure out a way to do that. And the insurance plan has to play the game, therefore, of fighting back. That's how the dynamic works. So the doctor or the providers comprise different systems, not connected to anything. So you have doctors who, some are connected to insurance plans right now, and they earn a salary. If you're a doctor who's a Kaiser doctor, Kaiser pays your salary. The majority of doctors are kind of like dry cleaners. They're an independent business. There is no network of dry cleaning, right? When you take your clothes to be washed, do you go to a franchise like Super Farm Dry Washers? No, you go to a neighborhood dry washer. Same thing with doctors in the United States for the most part, unless you go to a hospital. How do doctors and hospitals get paid? Anybody want to guess? You probably think by the hospital, right? Makes sense. They're in a hospital. No, fee for service. In a way, the doctor is giving them admitting privileges to work in the hospital. The doctor is renting space, like in the mall, right? In the mall, the Levi's store is not an owner of the mall. They're renting space. The doctor's renting space. And why does the hospital like it? The doctor makes recommendations for you to get lots of tests. Where are those tests located? In the hospital. Figure it out, right? It's like bakshish. One guy's paying the next guy. But that's how the system operates. I'm not saying it's good or bad, but you need to know that going in. It's not connected. Next, you have pharmacies. We have a lot of pharmacy chains. Walgreens, CVS, Duane Reade. These are mammoth chains that do share data. Not amongst the competing chains, but within the system, they share data. They know big data for them is looking at little data. They can tell trends saying that city has a lot of diabetes. Make sure we send diabetes drugs to those pharmacies. They're not living very long. You don't need to send drugs that prevent the onset of Alzheimer's disease, that improve cognition. They don't make it that old. They die of diabetes. Give them lots of diabetes drugs. That's how they use big data, down to the individual zip code. That's the balance between the big and the me. And you've got to be able to show that if you're in big data, make sure you translate that down to the prot, to the individual component. All right. Then there's the marketplace. The marketplace, if you're in the therapeutic end or the diagnostic end, you may not realize it, but these big systems like hospitals, how do they get their drugs? How do they get their diagnostic equipment? How do they get their technology? Well, individual companies like a Merck or a St. Jude Medical and Diagnostic, they don't knock on their door and come in and open up their suitcase and like selling like off a stand. It's not like First Station in Jerusalem where there are little shops that the hospital is going to. There are humongous distribution companies called Cardinal, AmerisourceBergen, McKesson. These are humongous distribution chains. They're like Federal Express of medicines and health products. And then last but not least, you have the policymakers. We have payers as well, payers and policymakers. And so what you look at often is you imagine it going into the system. And the companies that you're speaking to are eager to invest in you or buy it. There's a gatekeeper called the payer. And generally what will happen is Israeli companies that are involved in diagnostics and therapeutics almost universally don't do testing on the payer level. They assume it's great, and probably is great, but they don't assess, is the payer, the health insurance company, willing to pay for it? Or how will they pay for it? And the health economics of this is very complex. So I want to really touch on this for a second. There's a term in the United States called actuaries. And actuary tables, Levy, who has an MBA, can explain to you after I'm gone. He'll do a program just for you on actuaries, right? He will. He's offered to do this now. So that's a promise. Actuaries are effectively running health insurance companies. Health insurance companies do care about people's health, don't get me wrong. But they're managing economics, and they need to manage the cost of keeping you alive versus the cost of your dying early. They have tables. What happens if we don't treat it? If we don't treat it, they'll live 2 years. If we do treat it, they'll live 2.5 years. guess what the answer is going to be? And so a doctor has to make a request. Let's say the doctor has a suspicion, heaven forbid that you have a serious illness. And they have to get pre-permission to do a test. It could be a test that you've invented that provides very good data for the individual, not big data, but data. And the insurance company says, no, I'm not going to reimburse for that. This happens often. Happens often. And so most patients in the United States say, okay, and they go home. And you know what happens. Some patients don't say that, and they protest. And I will tell you in many cases that where I've had that happen, and I understand how to work the system, thank goodness, 100% of the time I've gotten what I wanted. But most people are not like that, and they don't get anything. So you have to figure that out as well. In your business planning, you have to anticipate this, because on the funding side, any smart funder kind of knows this system, knows this environment out there, this ecosystem, and they're going to filter your idea through this complex system. If you haven't figured this out first and said, this is our product, and we want to tell you how it will travel through and be well received by the payer, by the provider, by the patient community, and by policymakers. If you don't have those questions answered for the investor, you either have a very sweet, naive investor, you're incredibly lucky, or you figured out how to turn stone into gold, and I want to be working for your company. But if you haven't answered those questions, start thinking it through. Start thinking it through, please. So this is also something I'm kind of amazed when I'm here. So this is a very sophisticated nation. And this is the nation that created instant messaging. And this is the nation that created GChat. And yet, when you think of Israel's impact on social media, your use of social media, pardon my expression, sucks. That's an Israeli term, yes? Sucks? Yeah, okay. It's terrible. And often when I'm speaking to companies, and I'm privileged, my colleagues, I have a few here, Eli Hansen and Goel and others here, Ben and others, when I'm visiting their clients, the sophisticated ones totally get this. And the other ones view social media as, how many followers do I have? Like I only have 219 followers, and now I have 260 followers. This is terrible. They look at it as numerically. None of you, maybe 3 of you, are doing social media listening. Like, none of you, for the most part, I'm being pejorative, I'm exaggerating. But how many of you have in mechanisms, you're online using Twitter or LinkedIn or Tumblr or any of the venues of social media, not for your own ego gratification to be followed, but to follow and listen to. And because you don't do that, you don't get access to some of the best market research available in the universe with people who are active. So patients who are online, for instance, one of the things my company is very interested in from a pro bono standpoint is pancreatic cancer. I have a dear colleague of ours who was diagnosed almost 2 years ago with pancreatic cancer. Most people die after 6 months with pancreatic cancer. The bulk will make it maybe to a year. Hardly anyone makes it 5 years. So she's 2 years. We created, by the way, it's not a case that I'll present, but we created pro bono a crowdsourcing platform, which means we created a community online, because these people are often sick or consumed about their care all over the place, a crowdsourcing platform where doctors and pancreatic cancer patients can go online 24/7 to talk about newest therapies, where to go, who has a doctor that really is great, this. Because my fundamental belief, if you remember what I said, why I'm in this game to begin with, I'm in this game to make a difference in the world. My time is limited. It's finite. and I understand that. So this crowdsourcing platform allows patients and physicians who specialize in pancreatic cancer to communicate, because the standard of care, in my opinion, obviously isn't a very good standard of care. They die. How can that be a good standard of care if people die after 6 months? It's a crappy standard of care. I didn't want to tolerate it any longer. So I use these mechanisms for our own use. And what you have here are different, we have these tools. We have like 30 social media listening tools on board. He can answer more questions about it. He's younger than I am. I'm an old guy that was on social. He's a young guy in social media, so he's an expert. I'm not. It's a young man's world, a young person's world. But because you don't use social media to listen when you go into meetings with private equity firms or strategic partners, you just have no sense of the outside world. You have a sense of your innovation, but not what's going on out there. So one, put in place or get help, if it's appropriate to your business model, some form of social media listening vehicle, a loop. And measure your performance. And by the way, measuring your performance is not how you're doing, but how the issues, the topics important to your business are doing. So let's say you're working on an incredible diagnostic that uses the iPhone camera connected to something to transmit data to a doctor. And that's your thing. That's what you're innovating. And you're looking at the risk of eye diseases, glaucoma, macular degeneration, wet eye, whatever, and you're going to use the iPhone camera and transmit data. Track your issue. See where your issue is going. Can you imagine that you go to a private equity group and you say, I want to share with you a social media analysis of our space over the last 2 years. 2 years ago, no one talked about macular degeneration online. It was this, and now it's this. And this shows the growing market trend of how many people are coming online, what they're talking about, what the issues are important to them. You imagine going into a business meeting like that. That's the world, that's the customer speaking. That speaks to the value of what you're doing. You've got to not only put in place a social media mechanism for measurement, which you could later on use for marketing communications and enter the conversation. But many of you are in the conversation to sort of like, you want to talk about you. You don't want to be part of a community. You don't want to be part of the conversation. You narcissistically want it to be about you. Don't do that. Hope I'm not frightening them away, Levy. What do you think?
No, this was a nice touch.
Okay, you like that. So here's the reality of the American health insurance. You all said that you have your parents' health insurance plan still. Almost all of you. It's fascinating. In America, we change health insurance almost every 3 years. Every 3 years, we change health insurance plans, pretty much, more than 50% of us. My own company is changing health insurance plans after 2 years. We're ahead of the curve. What does that mean when you change your health insurance plan in the United States?
Why do you change?
Cost. So what happens is, to get you as a customer, everybody strikes a deal, even here, right? I want your business. I want your business. So they give you a good price. After they've got your business, they don't think of you as a customer to keep your business, to give you a loyalty price. They sort of say, screw you. You're in the mess now. Let me get new customers and give them a price. And they jack the price up like 50%. Yes, please.
How do you, in such an environment, how do you encourage preventive medicine?
We don't. We pretty much don't. We don't. And actually, health insurance plans have a big insight. Your question is very astute. The question is, how do we encourage preventive health? We don't. We don't encourage preventive. We do, in theory. That's why, by the way, I'm chair of the American Heart Association, because I am passionate. The heart disease and stroke remain the #1 killers of men and women in the civilized world for the most part. And why? We eat like crap, for the most part. We don't exercise, right? We rely on the fact that we were climbing the mountaintops at one point in our life. That should sustain us for the next 20 years, right? I think, Mark said, Pam Sankhan, Tamid Sankhan. Well, that doesn't really work when you're 60, right? It doesn't work. So, but we think of ourselves at that generation still, but our systems are collapsing. So to go to the point, not only do we change health insurance plans every 3 years, because 50% of us get health insurance by way of our employer, 50% of us buy it on the open market, on the exchange. Our health system was created post-World War II. And employers' health insurance was very cheap at that time. Do you know why it was very cheap? Bingo. We died early, right? That's why we had Social Security. We have Pensia. You went to Pensia at 65 in the United States because you were dead before you were 70. You paid in Social Security all your life, and then 2-3 years, maybe you survived and you died. It was a great gig for the government. Now all of a sudden, all of you Israeli companies are keeping Americans alive longer. You're screwing up our economy. That's the way you're going to take over the world. I got it. This is a very nefarious program that Levy has going on, and he's the real catalyst for the collapse of the American economy. That's why he left America. So the reality is 50% of us are get it through our employer, 50% of us buy it on the open market, and the employers switch every 2, 3, 4 years because the cost goes up. They're negotiating for a better rate with better deals, and so on and so forth, just like my company. Well, what happens when you switch health insurance plans every 3 years? I'll share with you what happens. You switch doctors every 3 years. So in America, when I grew up, historically, we had a relationship with a primary care physician almost our whole lives. I remember one of the touching things when I went once with my wife to her OBGYN. She was very young. We were visiting her family, and she said, I'm making a doctor's appointment. Would you sit there in the waiting room? And I said, absolutely. I'm a nice guy. I'm a good husband. I can sit there and read magazines like everybody else. And so I'm in the waiting room, and the OBGYN comes out. He's an old man by my standards then. Now he's probably younger than I am today. And he lovingly looks at my wife, and she had like a little mole on her shoulder. And he was looking at this very lovingly, very great concern. And it dawned on me way back when. He was an OBGYN, so he was now her GYN. But you know what he had been maybe umpteen years before? He had been the OB who delivered her. That's how long the relationship was. He knew her as this, and now she was, well, she's kind of short, but he knew her as this. So the reality is he had a relationship. We don't have relationships with doctors any longer in the United States. And so a good percentage of Americans not only have a relationship with a family physician for their family, but it's not bad, but it's convenience. It's cost and convenience. You know where they get their medical care now? A new business has opened up in the United States called the walk-in clinic. And the walk-in clinic is, I have an earache. My doctor from my insurance plan can see me in 2 months. I'll be dead by then. So I'll go to down the street and I'll call up 2 or 3 of these walk-in clinics in my neighborhood, and whoever has the shortest wait, I'll go see that doctor. You're no longer seeing the doctor because you trust them, or there's a relationship, or they know your health. It's, I got a meeting to go to soon, and I got to get in and out. What sort of healthcare is that? That's a transaction. That's a transaction. That's where the American healthcare system is moving. It's transactional. Telemedicine, I think it's great, by the way. I think it's all great. Access to care is great. I don't really care. But telemedicine is on the rise and will be growing. Walk-in clinics, growing. Cost and convenience. How much is it going to cost me? How fast can I get it? So also you hear this term, the consumer is king. Has anybody heard that thing in healthcare? The consumer is king. How can that be, the consumer is king? When did the consumer become Shlomo HaMelech? I mean, think about it. What king walks into a waiting room and is told you have to wait an hour and a half? Kings get served immediately, right? They walk in, everybody rises. The nurse at the window says, fill out this form. No, wait an hour. The doctor will see you. You're waiting an hour and a half. Then the doctor says, I can't do that. Your insurance doesn't approve that. Then you go to the pharmacy with a prescription. They say you can't get that drug. You get a different drug. Then you need a diagnostic test. There's a wait for 2 months. Who said the consumer is king in the United States? That's a perception. Consumerism is king. Consumerism is king. And that you have to write down or remember to understand the system is the king, not the individual. So communications is actually the new healthcare facility. Yes, ka-ching. How much is it going to cost? And how fast can I get it? Right? When you walk into the jean store, right, and they don't have your color and your size, but they say, I can order it for you, do you say, oh, that's a great idea. Just here's my size and my credit card. Or do you say, thank you so much, and you walk into another store and get your jeans right then and there? That's consumerism. I want it now. I want what I want it now. The system is thinking that way, not the patient and not the doctor, not even the insurance plan. The people involved in healthcare have literally are being swept along with the current. And when I hear the term, which is a good term that Israeli companies use, disruption, often what you do and you do well is you shift the system. You come up with an idea and you validate that idea. And this is where Israeli companies are brilliant. Israeli companies that really score big figure out how to, not how to work the system from a negative standpoint, how their innovation, regardless of where it is going to improve the system a little bit. Give me better information that I couldn't get, like the capsule you swallow that gives you the picture of the colon, but you can never get to that piece of the colon. And for a high-risk cancer patient who's very expensive, they can take a look and reduce cost. Big idea, right? That's potentially what it has been validated as a big idea. Israeli technologies come across, and they're generally not run-of-the-mill ideas like, hey, you got 50 of these, I've got the 51st. Israeli companies don't think that way. You think you have 50 of these, you really need this one. That's where you're really great. So here's what I want to leave you with this section of the presentation, then we're going to move on. Americans have an Amazon Prime-like relationship. I don't think you have Amazon here in this country. Do you? No. Amazon has become like, I think you hear it like Amazon, the company that doesn't own anything, but can give you anything you want, right? They're essentially a virtual warehouse company. You want a shirt, you want a book, you want a pair of shoes. They don't make shirts, they don't make shoes, they don't make books. You'll have it tomorrow. They're essentially a supply-side distribution company. They wouldn't say that, but that's what they do brilliantly. They reinvented the supply chain. That's disruption, and you don't even know it's disruption. That's what Americans think of. I want it now, I want it cheap, I want it my color. Next, accessible care is radicalizing the American healthcare system because we don't have relationships any longer. Formulary status, who is going to pay for it? Insurance companies want to understand the cost structure. And even if you plan to, your idea is I'm going to invent it and sell it and exit. I'm going to be the next guy or gal who gets $1 billion for my idea. Or how about 600? You list all these great deals all the time. So I'm going to get $60 million for my idea. How is the system going to pay for it becomes one of the big challenges. Have some inkling into that, at least. And then now, for those of you involved in drug development, the prescription pad is only a suggestion pad. 64% of prescriptions at the pharmacy level are rejected and the patient gets something else. Innovation doesn't guarantee pull-through. And I'll give you the best example. These cholesterol drugs that are revolutionary, the biologics called PCSK9s, they put your cholesterol back to the cholesterol of a 6-month-old. They can't sell them because the generic statins, the pills, cost pennies. The PCSK9s cost $14,000 a year. That's cheap for a biologic. But for a cholesterol drug, it's crazy. And the formularies say, no, we're not going to do it. Let them try all the statins that exist first, each one. And then if they failed on all those statins and we can't figure out how to do dialysis on their blood, maybe we'll do. They actually do that.
Actually, that also
Happens in Israel.
Same situation.
Yeah. That's why I think, by the way, from a closed-loop system, you're far more advanced than America. I think your perception sometimes is because of America's scale and big. Wow. We have like a medical system that is like, we're going to look back and say it's like the Middle Ages. But I represented for many years the Merck Manual, if you've ever heard of it. The Merck Manual is the definitive book on medicine. So I actually have a copy of the very first Merck Manual, the very first one. And it's very thin. Now, of course, the book is like fat, but the book was very thin. It's like a little pocketbook. It looks like a little siddur. And the treatment for almost every disease at that time was, in the early 1900s, you know what the treatment for almost every disease was? There was a miracle drug that was available at that time. What? Anybody guess? No, it didn't exist yet. You see, that's our age difference, right? Aspirin comes into play in the 40s. Arsenic. Arsenic, yes. Arsenic was the #1 treatment for people in the turn of the century. Yes. So you can get a sense of our American medical system. We've gone back to the future. Okay. So here, this is something I feel is true. Albert Einstein says, "I fear the day that technology will surpass our human interaction. The world will have a generation of idiots." So, fellow idiots, I welcome you to our world right now. This is where we're at. And your job is not just to innovate, it's to return the world to a place of humanity. So, we're going to talk a little bit about this. Now, this is true. You know, we talk about getting back to better healthcare. This is a cartoon of two cavemen, and one says to the other, something's just not right. Our air is clean, our water is pure, we get plenty of exercise, everything we eat is organic and free range, and yet nobody lives past 30. And so this is sort of the American healthcare system right now, right? We're trying to get to this pure state. Well, what happened back then in the prehistoric period? I mean, come on, we didn't have global warming. Everything was organic. I always say my grandparents, by the way, they ate organic foods. There was no refrigerator. There was no bringing it up from Brazil. There was no organically grown tomatoes. They ate organic food, right? But everybody died young. What is it? It's not just our lifestyle, in other words. It's not just our lifestyle. It is, by the way. I do encourage you as healthcare leaders of your community to live healthy lifestyles. I really do believe this. We have to exemplify ourselves as role models to the world. And Israel understands that to be a light unto the nations in different factors means we have to look at ourselves in the mirror and be a light unto ourselves. You can't be a light to others if you're not prepared to actually reflect a little bit and say, are we doing our best here as well? So this is how you can transform health. This is what's needed: patient monitoring technologies, drug delivery technologies, compliance assisting tech reminders, technologies that make the complex easier, software that improves patient throughput, and medicines to sustain life. If you can dump your idea into one of those line items, good. Good. It doesn't mean that if you didn't, bad, but good. Because our system is looking for efficiencies. That's really it. How do you make the system far more efficient in order for the system, the doctors, to make more money, and for patients to feel more convenience and benefit? That's how all this plays out. And these are the areas when I was thinking of coming here, this invitation, and I'm still grateful for the invitation, but when I was thinking of this invitation to speak with you today, I was saying, what can I direct you toward where you can make a difference. Israeli companies tend to do very well in these areas. I mean, there are outliers, good outliers, that really score big in other things. But this is stuff that's really needed and easy to explain a return on investment story to. So this is how you can improve health and make money. Improve adherence. You know, we have a lot of drugs, cheap drugs. I don't know if you know, by the way, almost 88% of the drugs prescribed in the United States are generic drugs. And in India, made in India probably, but they're not actually. We have a lot of problems with Indian-made generic drugs still. FDA is constantly stopping that because of the quality, and that hurts the generic drug industry. But we have a lot of inexpensive medications. We don't have people taking them. So let's say cholesterol drugs. I told you heart disease is the #1 killer of men and women in the United States. If someone has high cholesterol, the average length of compliance on a high cholesterol drug is 5 months, 9 days. Well, what happens to the cholesterol? It's still there. The high cholesterol is still there. The risk of event is still there. We haven't done anything. So there is an Israeli company, and there could be more, that's very involved in trying to think through MediSafe, trying to think through the compliance issue. Health literacy. The bulk of America, and we see this, by the way, there's a lot of discussion in the elections, like who voted for Hillary, who voted for Donald Trump, demographically. And there are two Americas. There's the America, the very sophisticated America, right, who believes in sort of human rights and who believes in education and all this. Very sophisticated America, which is really New York, where I'm from, and California, right? And maybe some dibs and dabs in between. You know, probably I would say Madison, Wisconsin, even though that Madison, Wisconsin went for Trump, I'm sure Madison, Wisconsin as a community voted for Hillary. And probably some place in Vermont where they're growing marijuana, not for medicinal use, that also went for Hillary. So that went for Hillary. And what else happened? People out of work, auto workers, right? Rust Belt, Iron Belt, coal miners, they went for Donald Trump. And guess who are some of the sickest people in America? Those people. And they don't understand the medical system and the directions. My data show, FinPartners data shows that actually the bulk of Americans, they get a manual when they join a health insurance plan. You know what their understanding of that manual is, of what they're entitled to? Like almost zero. So even if they have health insurance, thank goodness, they don't even understand what their health insurance entitles them to. It's hard to have preventive health even if you have health insurance, and you can have preventive health if you don't know how to access the preventive health. Health literacy, access to care. This is a big problem, and pharmaceutical companies and even payers want this process addressed, which is a very good, you have a cancer, is a very good drug, but you don't know about it and your doctor doesn't know about it. Don't be so surprised. When you have a big nation like this, it's not unusual. Insecurity. So it's true, we actually don't have electronic health records per se in the United States. We do and we don't. In 2008, I think 4% of America had electronic health records, 4%. Maccabi actually led the world probably in electronic health records. I think America was like right behind the Ukraine, someplace like that, electronic health records.
So when you switch health plans, you have to carry all your...
Worse than that. So because of HIPAA, which the previous presenters and Levy spoke about, HIPAA says you can't have your data transferred unless you agree to have your data transferred. That's true. So you have to sign, but more times your new doctor can't call up your old doctor and say, can you send Mrs. Smith's medical records over? I think she's having a heart attack in my office. Mrs. Smith is a new patient, a new human being. It's like she was just born. Because Mrs. Smith had to carry her records. And guess what? If you go to a walk-in clinic, is there an electronic health record there? No. No record. So our whole system is collapsing on its technology. And why? And this is where Israeli companies, if you're involved in electronic health records or data, the system never invested in security. Because the hospital system doesn't see itself in the IT business, it sees itself in the medical business. That's why so many medical records are hacked.
So many medical records are hacked that the price of a record has gone down. Supply demand. You can hack a lot of health records in the United States, therefore they're not worth very much in hacking any longer. It's amazing. No security, therefore the price per record went down. That's the global economy for you. The Russians must be very frustrated with this right now. Since they hacked our elections, most likely, who knows. So we have electronic health records in about 98% of our medical institutions, but they're stuck in those medical institutions. And as a patient, who owns your data? Think about it. It's scary. You don't own your own data. In the United Kingdom, the patient owns their own data. In the United States, they don't own their own data. And what's the basis of giving up your data? Trust. How can you build an electronic health system that works for Americans if there's no trust around the data? So if you're involved in that area, probably going to make a lot of money. Outcomes. That's really the value. We're moved from a price of the thing or the process to a value-based economy. By the way, someone I recommend you follow in terms of what he's writing, Dr. Mark McClellan, who was the former director of CMS, Center for Medicare and Medicaid Beneficiary Services. He is now at Duke, leading a think tank on reinventing the healthcare system to a value-based system. I think Mark is doing some very, very good work. He and I have disagreed often publicly, but in truth, there's great fondness and respect for each other. We're like Hillel and Shammai, I mean, in that respect. I don't know if you know that actually Hillel married Hillel's daughter married Shammai's son. So, no.
What's the last name? Mark?
McClellan, not Shammai. Mark Shammai. No, Mark McClellan. Mark McClellan. Cost. If you have a story that says this actually is going to improve care and reduce cost, good. And here's another thing. Keep it simple. Keep it really simple. That people come up with some, I've been blessed to meet a lot of incredible people this week. I mean, I would say, some of the most amazing people in healthcare in the world in this 1 week. My enthusiasm for what I do has only increased because of this visit. But some of their stories are very complex. And so if I was stuck in the elevator with them for like 5 minutes, I would leave the elevator saying, huh? But luckily, I sat with them for an hour. And so I got it. But I wanted to get it. Keep in mind that the other people are like, okay, what do you have to sell me? Okay, medicine is a team sport. In a team that doesn't want to work together. Keep that in mind. It is a team sport that's not working well as a team. And so this graphic kind of is you. All of these little, it's like a Monopoly board. All of these little houses and places are places you've got to visit to be successful. None of them are communicating with each other. All of them distrust one another. We have I would say the #1 problem facing the American healthcare system, and this is, I'll give you a true life story in a second, is we don't collaborate. Here's a classic example. My mother left this world about 1.5 years ago. She had uterine cancer, which, considering her son is fairly well knowledgeable of healthcare, she could have told me that she was bleeding out of her vagina, and I would have said, well, Mom, that's not usual for people in their late 70s to have menstrual cycles like every day. So she said nothing. Okay, that didn't help the situation. Then she got to see an oncologist who obviously did a massive surgery, and the tumor had fused from the uterus onto the colon. So she not only had a complete hysterectomy, she also had a partial removal of the colon. All right. Then she has to go into the chemotherapy. Moved her up from Florida to be near us. She has a place up there. And I'm very blessed. I have a wife. I recommend for those of you who have partners or something, get your wife to have a wife, because it's such a busy job that I don't understand how one wife does it so well. But this one is very efficient. She manages her clinical practice and family and my mother to that point, all the appointments and so forth. I'm kind of useless. I do take care of the dog, by the way. So I guess I do serve a purpose in the household. But in that respect, toward the end of my mother's life, she called me up and she was complaining of great pain. Great pain. And cancer pain is not unusual, but I'm not one of those people when people say, well, pain is usual in cancer therapy. I sort of say, no, it's not, actually. So I said, Mom, who was the last doctor you saw? She said, I saw a OBGYN at the hospital where she's going through treatment. I said, give me that person's number. And I call her up and I introduce myself. She gets on with me, so much for HIPAA. And she explains my mother's case of the recent visit. She said, I examined your mother because of the pain, and I saw she had a 16-centimeter tumor in her vaginal cavity. I said, that's about, I guess, size of a eshkoli, that's the size of something significant to be sitting in the vaginal cavity. I said, have you called her oncologist about this? Because she was going through chemotherapy. She said, I'm typing up the notes of your mother's visit, and we'll have to fax them over to the oncologist because even though we're in the same hospital, our computer systems don't speak to each other. So I said, I have a suggestion. Photocopy those notes, step up from your desk, walk to the other side of the building, and hand those notes to her oncologist. So I'll tell you the end of the story. She had to be hospitalized. She was having sepsis. And so they start to, if you know the treatment for sepsis, it's infusion, massive infusion. They hadn't consulted with each other because the tumor was now sort of resting on the kidneys, and so she couldn't pass the fluid fast enough. So effectively, they had drowned her. The fluid backs up into the lungs, and the person starts to essentially die of pneumonia. So I came in and suggested that they now had to begin some form of morphine therapy. The person really is suffering at that point. And I called the oncologist and the OBGYN and the nephrologist outside in the hallway, and they probably thought I was going to sue the hell out of them, right? It's a classic case of malpractice, again and again and again. And I said, have you learned anything here? And they said, we should have communicated with each other better. And I said, if you've learned that and you'll apply that going forward, we're good. The reason I said this, medicine is a team sport where people don't know they're on the same team. You, through your invention or innovation, you have to align. That's your job. You have to align the system. If you've got a great innovation, it brings people together. You've got to explain that in your business plan. This will bring these sectors together. So always remember this, big data leverages the many. I started with that. I talked to you a little bit about big data. This is, if you look closely at the face, it's the same face morphed through. Never forget that the big is about the one. So, some thoughts. Don't generalize. There is no average patient. When you walk into the doctor's office, tell me, do you want a doctor to say, I see a lot of you, come in. That's not very comforting when it's your ear that's bothering you. You want the doctor to reflect on your situation. One size does not fit all. If one size fits all, let's say with cancer therapies, we would use one therapy for all cancers. It doesn't work that way. We know it doesn't work that way now clinically because why does a cancer immunotherapy work incredibly well in some people and it doesn't work well in other people? It's the same cancer. It's the same tumor type. But you may not have the same biomarker. So one size doesn't fit all. By the way, anybody have inventing things that look at biomarkers in patients and therapies or tumors? You are? That's very hot and big in terms of maximizing very expensive therapies. Heterogenetic classes of medication. This is very scary. I mean that seriously. I jest a lot and I'm big tongue-in-cheek, but this frightens me. So you have drug classes where the drug is indicated and they say these drugs all do the same thing. This antidepressant takes you from a really bad place to a better place. we're only going to put 2 or 3 drugs on the drug formulary instead of 5 drugs. So we have a tendency to look at benefit, but actually we don't look at, again, the U, which is patients respond differently to different SSRIs, different antidepressants. So somebody you'll say is on an antidepressant, they're not responding. And you'll try another one, they're not responding. And the third one, they are responding. So keep that in mind. So I'm gonna leave you with this, and then I'm gonna take a few questions, which is man dying from cancer spends last good day on phone with insurance company. This is from a satiric magazine called The Onion. It comes out every week. I enjoy it. Don't be part of the satiric story. Make a difference. Make a difference.